Uh, Good evening, everybody. It's 6:30, so we can start. So I think we should start because otherwise we'll end up melting, won't we? So better the earlier we start, the quicker we can get out before we turn into pools of water. Anyway, welcome to today's meeting of the External Services Select Committee at the London Borough of Hillingdon. This meeting is being broadcast live on the Council's YouTube channel, Hillingdon London. The purpose of this committee is to monitor services provided by external organisations within its remit and review their performance. We also undertake in-depth reviews, witness sessions on specific topics, and submit our findings to the decision-making cabinet, and also make recommendations to those bodies that we scrutinise. My name is Councillor Nick Denys, and I am chairman of this committee. Before we start, I have some important housekeeping for everyone present. First of all, please ensure that any mobile phones are on silent. We're not expecting a fire drill, so if the fire alarm does go off, please follow officers out of the building. Also, if you could put your microphones on when you're speaking and put them off when you're not speaking, then that would be really appreciated, especially for those who are watching on YouTube. If the microphone isn't on, they cannot hear you. And as chairman, I will call those to speak during the meeting, so just put your hand up and I will note down. Okay, excellent. So let's move on to the agenda. Nikki, do we have any apologies for absence?
Chairman, we have no apologies for absence, but Councillor Money has advised that he's running a little late.
Okay, thank you for that. Does anybody have any declarations of interest? No? Fantastic. The minutes of the last meeting. Does anybody... Oh, right. Sorry. Yes, all items are going to be in part one, though at the end of the meeting, I will ask committee members to stay for a little longer so we can have an informal discussion about possible recommendations. But hopefully it won't take too long. So have those in mind when we're doing our questions. Okay, minutes of the last meeting. Is everyone happy with the minutes of the last meeting? Brilliant. Okay, excellent. So that takes us on to agenda item number 5, which is our review into children's dental services. So we had a very good meeting last time round in terms of investigating the issues and the complexities of provision of dental services within Hillingdon, so and also with some ideas about how to maybe improve the outcomes for our young people in terms of oral health. So I have we actually have 4 guests tonight. So if I could ask you all to introduce yourselves and the role that you play. So Richard, would you mind introducing yourself first, and then we'll go round.
Good evening, everybody. I'm Richard Ellis. I'm Joint Borough Director for NHS Hillingdon as part of North West London Clinical Commissioning Group.
Good evening. I'm Carol McLaughlin. I'm the Children and Young People's Programme Delivery Manager, also part of North West London CCG in the Hillingdon Borough team.
Good evening, everyone. I'm Caroline Morrison. I'm the Managing Director at Hillingdon Health and Care Partners, which is the integrated care partnership in Hillingdon.
Hi, I'm Shikha Sharma, Consultant in Public Health, London Borough of Hillingdon.
Thank you so much. So how do we want to start? Does anybody want to start saying a few words about children's dental health services? I'm looking around. If not, shall I volunteer somebody to speak? So I'm looking at Carol, and the reason I'm looking at Carol is because I attended a fantastic meeting at the beginning of about a month or so ago of a sort of informal group of people who care about this and can do something about this, to talk about what is being done. So if it's okay for me to pick on you straight away, could you possibly just give us a view about maybe why we have issues with child dental care in this borough, but also some of the work that's being done at the moment to try and mitigate and improve those issues?
Sure, thank you. So my involvement with this, we set up a steering group, a CYP dental steering group, back in 2019. And really, we have 3 aims in that group. The first was to oversee the rollout of a supervised brushing programme, which is essentially an initiative where children are encouraged to brush their teeth once a day, and it's carried in school. It's carried out in the schools. and there were 10 schools identified. Those schools were it was informed by a previous program of fluoride varnishing in schools in Hillingdon that were identified as areas of deprivation and where there was particularly high incidence of poor oral health or dental caries. So that was the first aim. The second aim was to ensure that a program called Brushing for Life, which is very much targeted at children's centres and early year centres, nurseries, and to support the ongoing rollout of that program, which is mainly delivered by health visitors and in the children's centres. And then the third aim that we had was to try to improve access to dental practices, and that work we very much saw as being taken forward as part of the supervised brushing. So when the work was being done in the schools, that we would encourage children to go to the dentist. So to fund the supervised toothbrushing program, that was funded by NHS England. So we liaised with them to get the funding for that program. Unfortunately, we were just ready to roll that out, and COVID hit. So that has really kind of broke our stride a lot. However, the oral health promoter has continued to engage with schools. There's quite a bit of preparatory work involved in training for the schools and also sessions with parents and to get consent. So that work has continued throughout the lockdown, and we've got a number of other schools interested outside the original 10. Our approach has been not to say no to any schools that have showed an interest, and some of the schools initially approached weren't ready. Obviously, because the program needed to be delivered in schools, with the school closed, that couldn't happen. And then when they reopened, obviously schools had quite a lot of other pressures. The plan at the moment is we've got 8 schools identified and signed up to start in September, so after the summer holidays. What our approach with that was, so we had funding initially for 10. If it became oversubscribed, we were prepared to go back to NHS England and look for further funding, but obviously we haven't been at that point just yet. The other thing that we've tried to do in terms of the Brushing for Life, that program distributes toothbrushes to children from children's centres, and unfortunately there are families in Hillingdon where they don't have toothbrushes, so can't afford, or it's not a priority. So that program is really important for that early messaging. So that's kind of where we're at, and we're doing, I think, what's within our control. And I guess with the steering group, the idea is that we've brought together partners from the local authority, from public health, from the children's centres, and also we have a GP on the committee. And some of the things we've talked about is, the idea that, so often GPs are looking inside children's mouths, and that we would get to the point where we would be able to signpost children from GP practices as well. So that's sort of where our focus has been. I think you probably talked about it the last time, the Staying Well program. That was really helpful in terms of getting dentists into the schools, talking to children, making them realise that they are friendly faces, and trying to encourage that that partnership really. And I also see that with the development of the primary care networks, on our radar was just the way we would link up the children's centres and the schools, we would be able to identify what was the dental practice in that area. So that's sort of the kind of work that we had, that we were doing through that committee.
Caroline, what's your sort of interest in this area? Because you're which is a very good thing for us, because obviously we know that you know the local health landscape very, very well. But But what's your sort of interest in terms of these issues?
Well, I suppose it stems all the way through from prevention of ill health and disease, right the way through to, as Carol was talking about, the integration of services. So it really is an area that I think we can maximise the good work that was started pre-COVID, and now that we've got a sort of a more formalised and I suppose more rapidly progressing level of partnership working, particularly around children's and young people services, actually for HHCP, is something that we can absolutely tie into our Children and Young People's Transformation Programme. So I suppose just a quick bit of context in terms of HHCP, where we started with the integration was very much particularly around the older population in Hillingdon, and that was mainly because what we wanted to be able to demonstrate fairly early on was that there were clear benefits to working collaboratively as partners. And at the time, one of the ways we could evidence that was around sort of supporting people to keep and stay well in the community, putting some additional case management at the kind of the older end of the population. And I think as we've then developed those programs, we are really conscious of the fact that children and young people are actually just as, if not actually more important in terms of our longer term ambitions for health outcomes. And I think particularly in the last few months probably, as I have to say over the last couple of years, the months blur with the kind of COVID response, but particularly with the work around the Children and Young People's Transformation Programmes, we've started to talk a lot more tangibly with colleagues in the local authority, colleagues in the primary care networks around children's services, and trying to knit together children's mental health services, the early years intervention, some of the children's centre working, young people's hubs. And as Carol says, we've then also got the opportunity to kind of pull the dentists into those local conversations around, the kind of making every contact count type element. We've just been talking recently in the Children and Young People's Transformation Board about what messages we might want to take out to schools in September to really try and get the really priority messages home to people, and this would certainly be one of them. So yes, I think we're at an earlier stage in our journey with the children's transformation and children's integration than we maybe were with some of the older adults populations. But it is now, I think, moving actually really quite quickly and coalescing around some really good integration work. So, I think our interest is sort of across the board, really, from prevention to actually the integration that would bring with it.
No, thank you for that. Richard, is there anything you'd like to add at this moment?
Thank you. I think there are a couple of things to add to what's being said. I mean, partly, as you'll have seen in your previous meetings, the responsibility, the health responsibility for children's dentistry is spread across a number of agencies. And there may be good historical reasons for that, but I think we have to look at what the impact is in providing an integrated service, as Carol is saying, for parents and for children. So you will have heard, I think, from NHS England about the work that they are doing. I guess our particular interest from North West London CCG is absolutely on the prevention side, because that has got to be where it starts and where the key work begins. But also at the other end of the journey, where dental surgery, where oral surgery is required, and this is a part of the jigsaw that the Clinical Commissioning Group is responsible for paying for and for negotiating with the elective care trusts. And I think what is pleasing is that there has been a real push on the waiting lists for children's surgery that have been built up during COVID. I think THH this week are running an intensive pediatric surgery week to try and clear some of those backlists. I was told before this meeting that I think there are 99 children on an inpatient waiting list at THH, and they're really trying to work that number down. And I think what is useful for North West London is being able to tap into some of the expertise in other parts of London, not only the Eastman Dental Hospital in Central, but also the dedicated Pediatric dental suite that's being opened up in Royal London. And I think our responsibility here is to be making sure that local children have access to top quality services, and to make sure that access and getting the patients there can be facilitated. But I think as Carol said, getting children's oral and dental health right is so important for the rest of their life, and so we're really keen to play our part in that.
Thank you. Before I invite other committee members to come in and give their opinions and ask questions, I wanted to draw a picture for you. And this is partly because it's sort of how my brain works. I was sort of having a chat with Nikki the other day about everything, how this all works, because we obviously when we first started this, I knew nothing about this this area of health, and you're right, it is multi-layered and complex. So I'm going to go over here, and I'm going to draw a picture of how I see the world, and if I'm completely wrong, please do tell me. So this might not work on YouTube, so everyone who's watching on YouTube, I apologise. But ultimately, okay, Nikki turned what I said into sense down here, but for me, it's a bit like a triangle. Here we go. Could be a house to build on. I used to have a manager who loved triangles, and I disagreed with her a lot, but now I'm drawing triangles in front of people, so it just shows you. But at the bottom of the triangle, you basically have healthy living. Yeah, I'll just put HL. So this is essentially eating well, not too much sugar, brushing your teeth, being educated, being informed about stuff. Then above the triangle, the next level, you have dentistry. I have access to a dentist. I can go to a dentist. They can give me advice. Then the next level is active intervention. When you go into schools, you do the fluoride treatment, you go into shopping centres and areas where you know there's problems, and you give out free toothbrushes, intervention. And then at the top, you've got emergency surgery. And this is, when children have issues and you bring them in and you have to give emergency surgery to remove teeth or whatever. And obviously, essentially, you don't want to get to there, but the better you do down here, the less important each stage that goes up, basically, is how I sort of see it. So, but obviously the biggest challenge is the bottom bit is obviously the hardest thing to sort out. So essentially, I think our recommendations are going to cover mainly these three areas. But down here, I was sort of thinking, well, we have the education issue. We have the sort of, when families get pregnant and they go into, and they have their checkups and all this sort of stuff. Are they told about dentistry, how important dentistry is to children from a very early age? When they're given information about, I don't know about anybody else, when I had my first child, the red book I got was like key, because I was like, okay, I'm coming home with this life here, OMG, I can't believe you've given me this responsibility. Hang on to the red book to make sure, I can be a good dad. But there was nothing about dentistry or the importance of, changing from bottles to cups and all that sort of stuff. So in many ways, there are some good tracks down here, which I think you could add a bit of dentistry to in order to try and improve a bit of education. Those were sort of my thoughts down there. I find the dentist thing very interesting, because we do hear issues of people not being able to sign up for dentists. Now, of course, technically it's a right, it's a free right if you're under 18 to have a dentist. Now, I wonder, we've spoken to a few dentists, and of course, as well as having to run a business, they have a public health obligation, and they want to meet a public health need. I wonder if there's a way we could organise to make sure that, for example, every single primary school child who's approached will be able to get a dentist. In the same way that everybody should be able to get a GP, because obviously, how I know so much about child dental care is because my dentist told me about how to do good things for my daughter. So, increasing that access for a dentist is very important. There's also the other thing up here, which is the credits, which is it called UDAs, which are sort of the credits for national health work. Now, we have this very strange system. If dentists don't use them, they go back to the NHS and they get lost in this, in the NHS budget. So, I think that's very interesting, because I would think that ultimately those credits that are lost, we should be able to keep in some way and use to benefit local sort of oral health, for example. So I think that's something we could look at. And then obviously up here, the programmes that are brought into place, such as, you know, putting fluoride into our water, going into schools, putting fluoride on kids' teeth, also, you know, teaching children how to brush and all this sort of stuff. So some more stuff around there. So, and then obviously, I don't think we'll say too much about the emergency stuff, because by the time you've got to that issue, then it's sort of way too late. So I just thought it might be helpful, or it might have been completely confusing, to sort of see basically that's sort of what I've learned over the last couple of months about this issue. So that's where I'm at. So I want the now I'll shut up and I won't draw anymore. So but ultimately, hopefully, in each one of those stages, maybe not the top stage, we'll be able to make some recommendations, you know, so they can work together to make sure that our dental outcomes are better. So does anybody have any questions or follow-ups or any views? Or before I ask committee members to put their hand up, because I've obviously bamboozled them with my drawing. June.
Yeah, I think this is addressed to Caroline. You're saying the Staying Well program with dentists involved in schools. Is it Carol or Caroline? Carol, where dentists are involved in schools. Who are the dentists, and how do you get them involved in school? Because we've heard from dentists that they don't even have time to actually take on people on their list because they're so overwhelmed with people seeking dentists. So who are those dentists that literally go into school, and what sort of advice is given to them? It'd be interesting to know. And which schools do they go to? Is it in the Northwest London area, or is it in the Borough of Hillingdon?
Thank you. And Shaker may be able to say a little bit more as well about this, but it was a scheme that was funded by NHS England, and they have run the scheme throughout London. But in Hillingdon area, there was 3 practices involved: Village Dental Practice, Harefield and Providence Road Practice, and Useley Practice. So they were the 3 that my understanding is that there was you could bid to take part, and there was particular funding arrangements, and part of that work was that engagement with the schools near to each of those dentists. So that idea was that they would go in and visit the schools and do some promotion, but also they invited families to the dental practice, and I think there was like an hour-and-a-half tour, and then they would do an assessment or treatment as well as necessary. So it was really kind of focused engagement, but with just a small number, I guess, of dental practices. So yes, in Hillingdon, but also it was run as a pilot, I think, or at least it started as a pilot across London as well.
Councillor, you're absolutely right that dentists are very busy, and it is quite a task getting them involved to work in schools. But I think some of the dentists do realize that unless they go upstream, if we consider the river scenario, people will continue to fall in the river, and then they'll have to pull them out. So they try to invest more of their time increasingly in preventative services in some areas, because that is a very good drawing. And I just wanted to say that a third, if we can imagine that a third of all of the children in Hillingdon, they end up utilizing one of the 3 services in the triangle, on the top of the triangle. And in some communities, it would be half of all children in those communities, black and minority ethnic communities, deprived social classes. So dentists who provide services to those communities find it more beneficial to maybe spend some of their time in the schools. So when we, in 2015, as Caroline said, that there was work done previously, when we tried to involve dentists, I think total 5 dentists in Hillingdon came forward, and they were very willing because they had seen the extreme end.
For those dentists who did that work, does that count as their credits under UDAs? Would they get paid for it in that way, for that community work?
I don't think it counted towards the UDA, but we did take money out of the unused UDA via NHS England to pay for their time.
And how did you do that? Was it quite a simple process?
It was during a year when Hillingdon had one of the worst rates in the country for very young children. So we could use that indicator to leverage some of the unused activity in Hillingdon.
Because I find that really interesting, because one of the things that came across my mind when I was looking at this is that the way the dentistry contracts is created and works at the moment is not brilliant, to be honest, and they need to be redone. But the problem is opening them up creates a big issue, so government hasn't been too keen to open them up. But ultimately, what happens is the UDAs are sort of the units that they get paid for doing the sort of national health work, and that's across the piece. It isn't, you don't have UDAs focused just at children. But if they're not used throughout the year, they're basically lost. So, if a dentist doesn't use all the UDAs that they're allowed to use, then it goes. Now, I was wondering if, it would be useful if those could be carried over, the ones that are lost, but then the ones that are lost, rather than being carried over for the individual dentists who might not have time to do the extra ones if they carried over, if it was put into a pot so we could be spent locally on those programs in the next year. Because ultimately it's one of those things where, okay, the NHS might get X amount of pounds back, but ultimately if we don't deal with the underlying issues, then it's like X times 10 that they have to spend, you see. And in a sense the money is there, but it seems to get lost every single year. I mean, does that sound like something that might be sensible for us to propose? I mean, yeah.
Yes, absolutely. Absolutely. I think that's fair and a sensible proposal.
Okay, does anybody else have any questions? Oh, Richard, yes.
Thank you. I mean, it sounds a very good idea. I'm a little out of date in the commissioning of the UDAs, and in any case, I'm sure COVID has driven a coach and horses through it. But my memory, when I was familiar with it, was that UDAs were often broken into 2 or 3 batches during the year, and so that there was a way of reviewing with dentists what proportion had been used and looking for the second half of the year to reallocate them in some of the ways that you described. Maybe that good approach that you describe has gone, but maybe Carol and I can do some work with NHS England and just check the UDA position currently, and, as you say, see if Hillingdon can benefit from some of the unused UDAs elsewhere.
I mean, when we've spoken to NHS England and local dentists, there's been no indication of that sort of thinking going on. I mean, and there is this money there to do stuff, and if it can't be done in a certain type of way, I mean, this year's been a perfect example where less people are going to the dentist. If that could then be used for the other programs that, and partly was inspired by attending your group, Carol, because there's a good group of cross-medical dental professionals wanting to do things, but one of the issues is where do we get the funding from? So, I mean, if you could look into that, Richard, that'd be really interesting, because I think it's something that strikes me as could be a good thing for us to recommend. Carol.
Thank you. And also, I think my understanding is the UDAs are not necessarily specified for use in children or adults, and perhaps if they were specified, that might help, and then we could monitor the usage based, of the allocation for children. So I think that might help, and that kind of feedback, because I don't think we have a mechanism to know But I think we have set up some of the foundations to work more closely with the practices, but we do need that information.
I think that's a very good point, actually, because the UDAs are sort of part of an antiquated contract, but if locally there were issues and strategically somebody could say, well, actually, could you concentrate more, if possible, in these areas, that could be quite useful for a more joined-up approach. Quite interesting. Debbie.
Thank you. It sounds like you're all doing some really great stuff. My questions are mostly aimed at Carol again. So what really struck me when you were speaking, I'm only basing this on what I've heard, is that it seems as though your interventions are based at the school level, and the very nature of public service is always going to be such that the demand for the demand or the need for these services is always going to outstrip what you can supply. I'm wondering whether you could perhaps think smarter about how you're delivering your interventions, and rather than delivering them at the school level, perhaps more at the individual level, because in every school you're going to have, even in the worst schools, for oral dental health, you're going to have 20 or 30% of the kids that are absolutely fine. Just blue sky thinking, perhaps having a very sort of low-cost, soft approach to sort of identify which children within those schools are in need, given that resources, your budgets are probably going to remain fixed for quite some time, could help you reach more of those children in Hillingdon that are in need. Again, my understanding of children and their morning and bedtime routines is that they are fundamentally dictated by parents, rather than children don't really have the autonomy, nor do they have the sort of maturity. They're not developed to say, hang on a minute, Mum, no, I'm not going to bed. I want to brush my teeth because some of them will be, most of them won't be. So again, are you aware of any evidence, perhaps if not any evidence, maybe what you have ascertained anecdotally as to how these types of interventions would compare, whether you delivered them to the parents rather than the children? Because, and again, that would need a lot of work, because we don't want to be condescending. These things need to be done very carefully. And that takes me on to my third point, which is about behavioural science. You probably already know about this, but humans are incredibly irrational, and that can be utilised to deliver really positive public health outcomes, in the sense that you can offer a tiny reward and people will react disproportionately. It's used a lot in developing countries to get child immunisations up. So in rural Indian villages, for example, they will offer a bag of lentils if you complete the child's 5 infectious disease immunisations. And the queues, people are completely irrational. So in this instance, perhaps a really attractive, something really attractive for children, a sort of attractive dental set. You know, when I was a kid, all I ever really wanted was a pink sparkly toothbrush, and had I had that, I might have brushed my teeth a bit more. So, can we think about something at a very, very low cost that will really help attract people that are perhaps on limited budgets and all the rest of that? Just a few ideas. Thank you.
Yeah, thank you. Lots of ideas there. Just to clarify, the supervised brushing program was targeting at schools mainly, but the brushing for life is carried out with in the children's centres and by health visitors, and that messaging starts, at the first visit from the health visitor. And at the children's centres, they do a lot of sessions on weaning, and so the message is stamped home at those. But it's true, not everyone goes to the children's centres, but that's where that core earlier message is carried out. And there is a mother and baby app in northwest London. I think, Nick, you raised this at the meeting about how do we promote through maternity services, and there is some information there. Again, it's quite targeted on the very early, sort of the neonatal period, but the idea is then it's taken up by the health visitors. In terms of incentives, it's one of the things that Sally, the health promoter, does is she sends out packs before the holidays, term times, and there's like activity packs for children. And she has run a number of competitions. So National Smile Month usually runs between May and June. And this year it was asking the family to create pictures of a healthy meal. And last year they had to draw a smile, and that generated a lot of interest through the schools, but also to families. And the goodie bag they got as prizes was a glow-in-the-dark toothbrush. So we have a little bit of this going on, but I agree, we could do a lot more. And as you acknowledge, some of this is resource. But I think we could for sure grow some of what we do. But some of those ideas are out there. And we've also, we have a character in Hillingdon called Aggie the Alien, which was used a couple of winters ago to get some messaging about accessing healthcare in winter. And the children did a writing competition through the schools as well. And we're using Aggie as well as this kind of character that is identifiable for children. So trying to, in terms of that behavioural science, trying to think of something that when the children see Aggie, they think about the toothbrushing. And we were fortunate to have 2 trainee GPs create a video last year. And throughout the editing process, we have incorporated Aggie, and that is at the point where it's due to be distributed more widely, and part of the messages, the key messages are included, but also accessing the dentist. So we've done a few things, but I agree, we could do probably more.
Caroline.
Yeah, and it was just building that point around resources, really. So obviously having messages from dentists and from health professionals is really powerful. But I suppose it's where else in people's communities they get influenced from and kind of take on board thinking and like I say, some of the nudging and behaviour change. So one of the things that we're probably in a better place now, actually, following the pandemic, is around some of our volunteer groups and some of our links into some of the communities and our wellbeing champions, our community champions. So I think we've also got an opportunity to get some key targeted messages out into the community more broadly that are just almost a kind of making every contact count type interaction, which is, do you know the importance of what are the kind of short, sharp things that you might want someone to leave an interaction with. It could be from your local pharmacist if someone comes in. There's a whole range of opportunities, as well as then having the kind of targeted approach, which I think we can kind of work on the kind of on that more healthy living type bit on the drawing up there. So.
Yeah, I mean, I think the healthy living bit, obviously, the 2 things about that is obviously if you get it right there, then the bits higher up become less important, which is good. But also there already seems to be a lot of work in the healthy living bit on things like obesity and other such health aspects. So, it feels like to me there are tracks already there that we could drop information in. I mean, is there any? I mean, do you have any views off the top of your head right now in terms of maybe are there certain programs that maybe adding a little bit about oral health might be beneficial and easy to do? If not, that's okay. We can we can think about it. But
I mean, as I said before, around the transformation programs across all of the children's and young people's care, it's a theme. What we're trying to do through the CYP program is set people up for a healthy life. So the earlier we can do that, and dental health is essential to that. So a number of the kind of the children's, the early intervention, the prevention, but then the kind of broader population elements, working with some of the kind of the integrated hubs around health and social care provision in Hillingdon. So I think there are. Yeah, the answer is yes. There's quite a few. I think it's targeting the messaging, targeting the information in a way that it sort of resonates, and then people kind of either later that day or in a few weeks' time when they walk into the pharmacist and see a children's toothbrush, think, oh yes, I remember that. So I think there's a whole. It's not just one approach, is it? It's kind of a multi-pronged approach, because it is such a huge issue for us.
Thanks. Thank you. Simon.
Thank you, Chairman. Just going on what you were saying then, is there, I mean, the NHS isn't known for being sort of the most straightforward organisation, easy to find various departments. Is there a single source of information, like teeth.com or something, where people can go to get the relevant information that is sort of easy to use and not complicated and doesn't direct you to 100 different places?
So at the moment it's probably NHS Choices, which is where we tend to direct, or 111 is the other, but that's more when people actually have something that they need to do or need some support with. So yes, it's probably not as streamlined as we might want it to be, and I think that's part of some of the work that we can do across the information locally as well to make sure that that's out there.
Thank you. Sorry. One of the things that we've been possibly thinking about is having a more organised approach within nurseries to supervised brushing. You know, because obviously those children who go to nurseries, you know, it's very habit forming if after you have your lunch, your teeth are brushed, basically, for example. A lot of this stuff is habit forming. I mean, is there, do you think there's any potential for promoting that, or maybe even setting KPIs around key performance indicators that must be met around those things to try and encourage those habits at a really early age?
We do have one, the Nestles Nursery Group, where have agreed to take part in the supervised brushing programme, but I guess some of that, it comes back to funding to broaden that approach. So we would need to source funding, I think, to do that. But yes, I think.
I mean, it might partly be a funding thing in some circumstances, but I mean, as a parent, I would appreciate it if I knew my nursery was teaching some really, you know, good life skills as part of what they were doing. And it would certainly be a positive for me, even if it was like a badge of this is what we do. Because ultimately, I mean, one of my children's 3 years old, and it is like a wrestling match every single morning and night when we're trying to brush the teeth at the moment. So I appreciate it on that level. But I you know, I think it's the kind of thing that I probably didn't really think about until I started this thing. But if you know, if there was a sort of badge with a smile, you know, or whatever, we do this. You know, as a parent, I think that would be a very positive thing in a nursery that I send my child to. Nicola.
Thank you, Chairman. Do we still use disclosing tablets in schools to encourage children? You know, those, I don't know if they're still around because I'm showing my age, but they, you know, you chew them and they're pink and it highlights your teeth, so you can see when you're cleaning whether or not you've done a good job. Does that still exist? They do.
Yeah, sorry, Nicola. They do still exist. I use them with my own children. So they are around, but I didn't know if other establishments use them or not. I don't think it's commonly used in schools, to my knowledge. So, yeah.
Perhaps that would be something worth considering, because it makes it an engaged activity. Then, you know, start with pink teeth and end up with white teeth.
Sounds like fun.
Maybe glow in the dark teeth. Does anybody else have any questions at this moment? Okay, Nicola.
Sorry. You said something earlier, Carol, about that in some households toothbrushes are not prioritised. Does that automatically then flag that, you know, if a parent won't prioritise a 25p toothbrush because they are that inexpensive in supermarkets, does that highlight that perhaps there's other areas that are being neglected or not prioritised? And so there could be bigger issues around, you know, that it starts with not being able to provide your child with a toothbrush, but then, you know, is that child getting an apple a day and regular milk and those kind of things? Does it create a trigger somewhere along the line?
Yeah, I think there are those links with deprivation, and a lot of the targeted work that's carried out is for those families and those communities. So that's the sort of work that the health visitors would be monitoring and involved with. So that's very much where the targeted work goes. I think just another point really about sometimes we have these initiatives and we bring in new initiatives. I think with the oral health, that for me there is something about having a sustained program that, you know, has the core funding constantly. Like we have a 3 or 5 year plan about where we expect to get to. So thinking KPIs, we know that we've got 32.5% of 5-year-olds with dental caries. Where do we want to be in a couple of years, and how do we monitor that progress? But we have a focused, sustained approach to that, and I think that would be really welcome.
I think that's a very good point, Nicola, about and one of the things that we certainly picked up during this investigation is that oral health is linked to many other, you know, issues as well. So it is all interlinked. Peter, have you got your hand up? Okay, great, fantastic. So if nobody's got any other questions at this moment in time, Shika, do you want to come in on that? Yes.
Chair, I just wanted to add that sustainability is a key issue. As Carol said, we have 4,000 plus new children every year, and if we have ad hoc programs which are funded for short term, only in a couple of nurseries or in a couple of schools, then we will be in the same position year in, year out. So sustainability is one issue, and the second issue is the reach. It's important that we upscale these programs to ensure that we cover the whole population, maintain targeting in certain areas, but also covering a wider population. Thank you.
As we've come to the end of questions, if it's okay with everybody, it won't surprise you to know I'm not going to draw any more, but I've thought of some possible recommendations that I want to sort of throw out for the committee members and for yourselves as health professionals as well to give views on, because ultimately we don't want to recommend anything that's balmy or impossible to achieve. So I mean, one of the things, it's all sort of linked into sort of trying to help along this sort of triangle here. I mean, one of the first things that, you know, I noticed the funding point is very important because, for example, with the sugar tax on fizzy drinks that we all know has come in recently, the money from that is targeted at tackling obesity. Now, it goes into programs such as teaching parents how to cook healthy meals, for example. Now, you know, I think we could possibly recommend that oral health should also be counted as a factor for targeting for those sort of assistance, because ultimately they're also linked. If somebody has bad oral health, that might be the first sign towards obesity as well. And I mean, ultimately, it's one of those things I possibly think, because the negative effects aren't really seen till later on in life. But you know, if your teeth are not very good and you don't feel comfortable smiling, you know, when you become when you start to become an adult, I mean, that could really potentially affect your confidence. But so that was one of the things I was thinking maybe we could try and sort of propose. One of the other things, based on what we were saying today, is about, you know, the information being provided to maternity patients in their red books, and as the process goes, you know, don't forget about dentistry. It's free. It's free for you as a woman who's pregnant for the year before and the year after, and also actually for your child up until 18. And it's one of those things that, you know, it's a free public health benefit. It's great we live in a country where we do have that free public health benefit. You must use it. But so, you know, repetition. I mean, I know one of the problems with dentistry is some people are a bit scared about going to the dentist, so, you know, those messages need to be repeated. But if we can stick those repetitions in at key points where they're maybe not mentioned now, I think that would be pretty useful. What I would also like to do is I would like to ask the sort of Federation of Local Dentists to make a commitment not to turn away any child under the age of 11. And that might be, they might have to come together to sort of pool that. So if dentist A has 10 requests, you know, maybe they'll have a system where that can be spread across. But I don't like the idea of a child not being able to become part of a dentist, because a dentist isn't just looking in your mouth, it's giving you that education as well. And also, you know, if you do things when you're younger, you're not scared when you're older. So that's something that, you know, I was thinking of. Obviously the UDA point about if we can use the money locally, keep the money and use it locally, and maybe use it in different ways if individual dentists aren't able to use it. I was also thinking, I've written down here, better training for health professionals, such as health visitors, school nurses, on promotion of oral health. Now, that does happen, but does it happen across the piece, and how regularly does it happen compared to other things? Is it something that some do and some don't? My feeling was it was a bit patchy, but then I've heard more evidence that actually that does happen more than maybe it does already. But But if that could be across the piece, that would be useful as well. Also push for water fluoridisation. So across the country, putting fluoride in water is being used to sort of improve oral health benefits. What I'm told is London's too complicated, which I think, well, if it's complicated, then we should start doing something now rather than not doing anything. I've been told that actually because it's so complicated, it's not worth doing anything on this. I take the opposite view. If it is a public health benefit, then we should try and get the other London councils involved to do that. So okay, and I from a Hillingdon point of view, the select committee which has responsibility for this area, the Family Health and Wellbeing Select Committee, should get an annual report from Public Health on the performance of community dental services in Hillingdon, because after we finish this we'll move on to other things. Our remit isn't we'll go back a year later, but then that's it. But having a constant sort of monitoring from the council I think would be useful. Obviously supervised brushing in all nurseries, can we push that, either obviously funding where necessary, but also by creating schemes where nurseries sign up to doing that. And also I'd like to ask the Health and Wellbeing Board to oversee a comprehensive communication and education plan. Now, I just think, if we do that, then hopefully it can improve a lot of things in the bottom quadrant, but it needs to mix everybody together, who's all our health partners. And again, we as a committee, once we've done our report, we'll step away. We won't really get too involved in this. But I feel like the Health and Wellbeing Board is where a lot of those actors will be together. So that's, I can't sleep at night because it's too hot. That's what I've come up with so far. But I just wondered, do any of those sound good or not good? So does that sound like? And this is just stuff from all the conversations we had. I haven't created this in the bubble from all the meetings we've had. And so that's lots of nodding heads at the moment. So that's good. Okay, so yeah, does anybody think at this moment in time, is there anything else that we'd like to add to that? Obviously, I've taken the point about maybe being more strategic about the use of UDAs as well. But does that sounds good? Okay, Simon.
No, I was just going to say, Chairman, I think the most poignant part you made there was the monitoring aspect of it, because as you say, we look at this every couple of years, every 3 years or so, whereas if we could have somebody monitoring it, I think that's the critical point. Thank you.
Okay, so everyone's happy, so that's great. I should draw more triangles in meetings. Obviously, I bamboozle everybody with my old manager was right. Anyway, so if that's everything for now, Richard. Yes.
Sorry, just to pick up on those suggestions, which I think are an excellent list. It makes me think about pieces of work that we have been talking about in recent months about how to be joining up some of the campaigns. And I think the point was being made earlier on around are we missing a trick in, for instance, when we're promoting COVID vaccination, are we also promoting cervical screening or maybe promoting dental health and so on as well? So I wonder if that's something we can be taking away and looking at. Also picking up on your point about giving more information for pregnant women and for the young families. Pregnant women will be a priority group for the flu vaccination campaign this autumn. And of course there has been an issue about offering COVID vaccinations to pregnant women. And so again, I wonder if there's something about telling the story about prevention and building up protection against a number of key issues, and that may be something, maybe Aggie the alien comes in, I don't know, but there are maybe some quite simple messages that can pull some of that together if we think carefully and work with the key groups about targeting those messages right.
No, thank you, Richard. It's something that struck me very early on, that there are these tracks already, and if we could just drop something in, it could make a real good difference. By the way, we did invite Aggie to come tonight, but unfortunately Aggie was busy doing good somewhere in Hillingdon, so couldn't make it. But no, that'd be really appreciated, Richard, if you could look into that as well. Thank you very much.
Thank you, Chairman. Following on from what Richard was saying, I think the initiative can be around what you can have for free, because people like free stuff. So if it's based around that, free screening, all of the, free COVID, free flu vaccination, all this free stuff, and that will engage people quite quickly on, based on what Debbie was saying about human nature.
Okay, so I'll call that part of the meeting to a close. We are going to be discussing phlebotomy now. Caroline, Carol and Shiki, you're welcome to stay, but you're also welcome to leave as well. So, okay, Richard.
Thank you, Chairman. Thank you. So, changing gear to another part of the health service. I'm really grateful to this committee for making room on your agenda for us to bring you up to date on local phlebotomy services in the borough. It's quite a long report, and I'm not proposing to take you through it in detail. But I think there are a number of key points maybe that I can pull out for you. One of those is just getting the definition and the language right. So phlebotomy, in other words, taking samples of patients' blood for testing and analysis at laboratories, therefore helping the clinicians either to rule out some health conditions or to signpost towards treatments and other conditions. It's a really basic part of healthcare. Around, leaving the pandemic aside, probably 3,000 or 4,000 samples of blood are taken every week across Hillingdon, and and in a way, rather like dentistry, in a way, not many people like having their blood taken, but it is something that goes with the territory of contact with health services. Now, as we've set out in section 1, the provision of blood-taking services, of phlebotomy services, was traditionally in Hillingdon a hospital-based service. And the impact of COVID really highlighted that there were issues about that basic clinical service being offered, where patients perhaps had to queue up, where they had to wait in quite cramped waiting conditions, where the clinicians taking their blood and obviously being very close to them needed to protect themselves with PPE and so forth. And so, among all the other things that hospital and health services and patients were having to deal with during the pandemic, the safety of a hospital-based phlebotomy service very quickly came under scrutiny. And as we begin to set out in section 2 on page 20, in a way, certainly in hindsight, I think what's been happening with phlebotomy is maybe quite a rare example of the threat and the danger and the challenge of COVID actually turning into some opportunities and some real benefits for patients about having another think about the way the service was delivered. And so we've taken the opportunity of really moving a hospital-based service based in either THH or at Mount Vernon to a practice-based service in primary care. And that is, after all, the way in which most of the rest of North West London and most London services do offer phlebotomy services, to enable patients to be seen closer to their homes, to have their blood taken as part of the examination, the investigation within general practice, rather than sending them off to the other side of the borough for this, as I say, fairly basic investigation to be taken. The rest of page 21 describes some of the stages that we rolled this out, really between August last year and January this year, through the ups and downs that we remember of lockdowns being lifted and then being reimposed and so forth. But now in July, certainly for the whole of July and for most of June, every practice in the borough is providing primary care-based services for phlebotomy. And Mount Vernon is still providing blood-taking services, both for urgent patients, but also for some routine appointments and some specialist appointments. But in a way, we don't want to stop at where we've got to in terms of developing a primary care service. We want to be monitoring the numbers of patients that are going through, the waiting times, the numbers of appointments that practices are offering. We want to get the volumes of blood samples at the right rate. And we think it's probably possible to transfer more blood-taking services from Mount Vernon to primary care. And one of the recommendations of the paper is whether this committee would be interested in receiving a regular update, perhaps at your September committee and again in October, as to where we have got to in consultation with patients and in discussion with staff, to see what can be safely transferred closer to primary care. I think what has also been really rewarding, and we've put out some examples in the appendices to the paper, is how immediately welcomed a primary care service was by patients. It seemed the right thing to do. It is the same thing that most practices elsewhere in London are doing. It seemed the right thing to do, and almost overnight, patients were saying, "Does this mean I no longer have to look for a parking space in Hillingdon Hospital? Does this mean you can take the blood here and now, and I can get on with my life? Does this mean I no longer have to wait in a queue at the hospital?" And I think some of those comments on page 25 are just really heartwarming to hear. I wouldn't want to paint it entirely in rose-coloured spectacles. There are some challenges. Some patients we know do like a walk-in service. Clearly many patients do live near either THH or Mount Vernon, and they liked that opportunity of being near the hospital. But we're working with practices, and certainly practices saying that they like it and our patients like it. And we're also looking at how the best way to resource blood-taking services in general practice can be. We're negotiating with THH some transfer of the money that is traditionally within the hospital budget, funding the hospital-based clinics, to come into primary care. And as always, there are advantages of a centralised service, there are advantages of a localised service. The advantages of a centralised service is that one van turns up once a day, picks up the samples, takes them to the laboratory to be processed. Clearly with 45 practices, then a van needs to be making the rounds several times a day to pick up the samples. So we're costing that up, we're working that through, but we think at the end of the day there are benefits of sustaining that local service. But as I say, we would really welcome the opportunity to come back and brief you over the next couple of months as to how that's gone, and if the initial flush of enthusiasm from patients has been continued, and if it's still working well from practice point of view. The appendices also attach the equality impact analysis, where we tried to assess the risks, the benefits, the opportunities, the potential challenges of the service. So I'd really welcome any comments or questions arising from that. But I think I'll pause there, Chair, if I may, and try and answer any questions that you may have.
Yep. Just firstly on the meetings, in October and April we have a sort of our general health updates where you and others come along. So the next one's in October, so that sounds ideal for a further update.
Terrific.
Yeah. So June, you had your hand up.
Yeah. Thanks for this. This is quite an Thanks for this, Richard. This is an in-depth thing, but dear to my heart as well, because with the service that was provided at Hillingdon was really a tedious service. So I was happy to see that my GP was one of those GP partaking in the GP providing it. brilliant. There is an obstacle though. They're only allowed to take a certain amount of people before midday because of the collection time of the blood. So somewhere along the line, working with other GPs to participate, we may look at the extension of how that is going to be, and that might help to work. In regard to some people wanting to be in the vicinity of a clinical area, you know, it's to do with trust, it's to do like some people believe that it's a hospital setting, they prefer that than going to GP. Not quite sure who it was, because I myself was a bit skeptical. Who is doing bloods at my GP? I hope it's not the HCA who does other things. But fortunately, there was a phlebotomist there. So I find that rather helpful. The waiting to be able to get your phlebotomy service at your GP, it's a long time. So if you need a blood test done, your GP may recommend a blood test. It doesn't necessarily mean you get it that day or that week. You may have to wait the following because the waiting list is so long. So that might be something to look into. And coming back to us with figures and statistics would be helpful to see how many GPs is encountering that sort of problem. So some kind of a table or guideline would be helpful with that.
Yeah, no, I think that's a good idea, June. Does that sound reasonable, Richard, as a request?
Yes, thank you, Councillor Nelson. I mean, just to pick up a couple of those points, some practices are providing morning-only clinics for exactly that reason, so that they can get the results back that same day from the laboratory. But a number of clinics are running afternoon and I think early evening clinics, and clearly we're running the pickup and taken to the laboratory so that they can be processed quickly as well. And I think this is part of the learning for June and July and beyond, as to what the level of demand and activity is to get the right numbers of patients flowing through, so that the phlebotomist turning up at the beginning of the day knows roughly how many patients that they will be seeing, and obviously not sitting around doing nothing, but also not being run off their feet and having waiting times. And so I think that is something that we'll want to be talking through with all practices, about what the level of service, the numbers of clinics that they run during the week is. And as I say, we also want to look at whether some of the urgent tests, where the GP sees the patient that day, that morning, for instance, and he's sufficiently worried about the patient that they want the blood test taken there and then, the results back that same day, so that the GP knows what best to do, rather than asking the patient to go up to A&E and potentially wait for hours there before being tested. On the recruitment point, I mean, you're absolutely right. The practices are only recruiting accredited and trained phlebotomy staff. Many of them, of course, have been working in the hospital or in the clinics, because a lot of them were sessional or part-time staff in any case, and therefore it just made sense and was very easy to negotiate their contracts with the practice rather than with the clinic. But they're all properly trained staff. And I think your other point about waiting times is absolutely right. We want to make sure that the capacity that is there at the general practice is right, not only for the numbers of patients registered with the practice, but also the ages, the cohorts, the sorts of conditions. Some prevalence clearly will need blood tests taken more often than others. But hopefully for October, if we may come back, we'll bring back some detailed figures and statistics, trying to show the pre-COVID position, but also showing what's happening at the moment.
Nicola.
Thank you, Chairman. Richard, has there been any investigation into community nurses providing phlebotomy services, or a community phlebotomist? Because, as you were saying earlier, there's an awful lot of people that have routine bloods done. You know, elderly people have routine B12. We know when that's going to happen. It's easy to schedule. And at the same time, that person, you know, can take blood pressure, SATs, and pulse, just a general quick snapshot, which can then be fed back into the GP without exposing that elderly person or disabled person to other risks of going to a GP surgery. And it's usually, I'm sure you know, that things like blood pressure, etc., are a lot lower in their own environment. But after someone's hefted their way on a bus and all the rest of it and sat and waited in a waiting room, they're generally a lot less relaxed than if you pop in. And also, from a phlebotomy point of view, if somebody's relaxed, it's much easier to get into the vein, draw the bloods without leaving a bruise. Is that being explored?
So there are some community teams already, and for housebound patients, or for some of the care homes, the visiting community team will be taking the bloods. But I think that's an interesting question about whether a community clinic for other purposes could also be taking the blood for those patients, and I guess that's something we should be looking at. I guess, you know, as always, it's the fine balance, isn't it, around the training and the skill of swiftly and painlessly taking the blood and being able to relax the patient. Depends on being able to see a reasonably large number of patients every day, rather than somebody doing it, you know, every now and again, you know, rather like Councillor Nelson was saying. But let's have a look at that. I think now that shift of phlebotomy into the community, into general practice, has been taken, I think now there will be lots of opportunities that occur because of all the work that the GPs will now be doing through diabetes, through weight management, through a lot of the long-term conditions. Some of those will require bloods being taken, and there's just the opportunity of offering a bit more of a one-stop shop, I think, for patients. Yeah. Thank you.
I have to say, I think phlebotomists are up there with hairdressers in terms of their conversational ability. I don't know if that's part of their training. But whenever I've given blood, very very good conversation, and suddenly it's gone. But Hina.
Thank you. I just had a quick question, getting my head around all the different acronyms. On page 20, the third paragraph, IPC expectations. What does IPC stand for, please?
Right. I was being shown an NHS quiz earlier today with a whole lot of acronyms that I wasn't able to decode. I'm so sorry. IPC is infection prevention and control. Yes, I do apologise. Thank you.
Maybe for our Christmas meeting we could have a NHS acronyms quiz. Or maybe not. Yes, June, go for it.
Where a phlebotomist is concerned, they're rushed off their feet, and to do blood pressure and do those little bits and pieces, that's an extra job that really they cannot take on at the present time. Quite a hectic job doing bloods.
I'm actually a qualified phlebotomist myself, so I am familiar, and I've found it quite useful to be able to incorporate the other things, because it saves an awful lot of GP time to have somebody that's effectively relatively low paid doing that work in the community.
I think this is something obviously for Richard to consider across the piece as well, you know. So it's a good point that June makes, but obviously, you know, if it can be built in the right way, so it'd be interesting to see. The point I wanted to make is probably the overarching point that everybody's make. I think this comes down to access, really. So, you know, going to Hillingdon Hospital, Mount Vernon, you know, can be annoying in many ways. You have to pay for car parking. You don't know how long you're going to be there for. Mind you, with the improved Wi-Fi, I can do my work email, so it's not so bad as it used to be. But ultimately, if it was a case of that, you know, when I want to have a blood test, it's a 3-week wait, for example, then that's not so good as well. So, you know, having that sorted and monitoring that, I think, would be pretty useful. And it strikes me as this is something where it could be shared, you know. So I have my GP in Eastcote, that's fine. If I could do it there, brilliantly. But ultimately, any GP within a sort of 15-minute drive of me. I'm, you know, taking my blood. So if there was a way, if I was booking it, you know, through the NHS app or whatever, and it just showed me what days and where I could go. If I could go to a GP in Ruislip, for example, get it done in 2 days. And if it's possible to do some linking up like that, I think that could probably help that. Yeah. So I think those for me are the two really big issues. You know, it's a good idea as long as people have access within a decent time. Because generally I wait till the last minute, you know, before I do this. And so the one advantage of the current system is that I can, even if I have to wait 2 hours, I know I can do it before I'm seeing my doctor.
Thank you. No, those are two really good points, and we'll certainly do our best to monitor those for the next report. And I think the point about sharing resources. Again, the vaccination programme, as you were just saying, has really shown the impact that practices can deliver if they work together and if they work with pharmacists and so on. And I think there is more scope for that around phlebotomy as well.
Thank you. So is everyone happy? Yeah, brilliant. Okay, so we'll get an update on how things are going in October. Richard, thank you very much. Okay, I think we're on to our work programme. So Caroline and Richard, you're very welcome to leave now. Thank you very much for coming on this very hot day.
Thank you very much. Thank you.
Right, in June as well, yes. So there isn't much to say, I think, on our work programme. He looks at Nikki, he's shaking your head, that's great. Just one thing to note is our next meeting on the 15th of December, we're doing crime and disorder, but slightly different from normal. We're going to concentrate on Neighbourhood Watch and the OWL service. So, yes, any views, you know, while Nikki sort of thinks about guests and all that sort of thing?
It was more last September we did crime and disorder, but we tagged on the end of the meeting Hillington Hospital Development Build Review. Considering it's been quite a few meetings ago since we had an update from them, I was wondering whether we could potentially, even if it's just a short period, have an update on how that's going. Not about because obviously the next meeting we're doing the trust.
Yeah. No, happy
just
to do that.
Specifically about Hillington Hospital, and possibly if there's a new chief executive, they can come in.
I don't think there'll be a new chief executive by then. We have, on the 27th of January, we've got a full meeting on Hillingdon Hospital, and the reason why that date was chosen, because essentially they're going through this public consultation at the moment, then they're going to be putting their plans into planning in November, sort of December time, so that seemed like a good time to have a big full-on meeting. But having an update at the next meeting before then, I think it's good. Yeah, no, indeed. I think that's a good idea. Before we have that meeting in January, having an update about how the consultation is going, for example. So I'm sure, Nikki, you could invite somebody. So we'll put that on. So if anybody's got any views at all about who we might want to invite for the Neighbourhood Watch and OWL, and the purpose of the meeting isn't just to talk about the crime stats and get the police's view, but it's also to talk about engagement with neighbourhoods and how to, you know, resolve crime. So
traditionally we've always had somebody quite senior in the police come and see us. I'm wondering whether it's worth having sort of a local street, I don't know what you call them anymore, street bobby as such.
Safer neighbourhood teams.
Or you know, somebody who is just a constable who is out working the streets rather than somebody who's really senior.
Okay, that's a great idea. Yeah.
Because they're so well versed in all their party lines.
Yes, indeed.
And I think for us it would be so much more interesting to hear someone who hasn't had that.
Yeah.
I don't know whether the police will agree to this, so that's the only thing.
True.
I would love one of our community support officers to answer some of the big questions.
Yeah, no, in terms of a practical level of how this operates and how you interact with the community, I think we can definitely ask for it. We have a very good case. I mean, I agree quite often. I joke with people that, you know, we look at the NHS and we look at the police. The NHS are they're oversharers. They come with you lots of PowerPoints, lots of information, while the police just straight back. You know, they're two very different meetings when we do health and police. Which is why I sort of wanted to have a different angle on the next one, you know, getting that involved. But I think it's a great idea. So, Nikki, if you could see about if we could get somebody who basically manages a safer neighbourhood, trusted local constable or whatever, that'd be great.
Also, Chairman, the community engagement with schools, because that's where a lot of crime starts.
Yeah.
At the risk of talking about ward work, we have to do nice sweeps and so on with the local police, because a lot of parents have no idea that their otherwise very well behaved children have stashed knives because they feel they need to protect themselves. And so what are we doing in schools to try and improve on that?
Yeah, no, that's a very good point. That's a good point, part of community policing. So yeah, if we could cover that angle at the meeting, that'd be very good. Nikki. Excellent. Any other views? No. Okay. Oh, yes. So my original idea is, well, once we finish the meeting, we'll have a quick chat about the final report, because at our next meeting, it will be presented to us for us to sign off. But obviously, I want to make sure that Nikki has a good direction from us before she goes off and does her work. Just once this meeting's over, if we have a quick informal discussion about what we discussed tonight, that'd be really useful. Okay, so I will bring this meeting to a close.